access to these because I put a bit more and then I truly have 10 minutes worth. I will say one little editorial comment. All of these are peer-reviewed papers, and one of the points which is just made before, there's been enormous influence of celebrity academics, typically not doing what I would call the traditional approach to science, which is to submit ideas to the scrutiny of peers and so forth. And so, you know, as far as I know, the Imperial College paper is still a working paper. It wasn't subject to peer review. Most of the things in New Zealand are not being subject to peer review, which have been highly influential. And so my approach is rather more traditional. And so I've put links here for people who want to look at the whole papers. One of them is not on New Zealand, it's on Indonesia. Someone earlier mentioned India. We estimate that in Indonesia, about 20 to 25 million people are going to go into poverty as a result of the lockdown there. And the people who are going to lose years of life as a result of the income shock is at least 10,000 times larger than the lives saved from the lockdown. So I'll show you a similar calculation for New Zealand. It's nowhere near as extreme. So in some sense, we're very lucky in New Zealand because we live in a place where things are not as dire as the trade-offs are in India and Indonesia and so forth, right? But otherwise, I use the same framework in New Zealand. Okay, so as I said, right, New Zealand case, it's really been dominated by these SIR models, basically mathematical simulations, Imperial College, the COVID sim used by Michael Baker and co, and the TPM Hindi paper. And there's lots of issues with these. These don't account for various aspects, as we've learned more, and so they typically assume constant reproduction rate or homogeneity, so they don't allow for over-dispersion. They don't allow for selectivity in terms of what might be the herd immunity threshold. For my particular area as an economist, there's two big problems with these. And so most of the time, they don't have a mechanism to allow for the fact that people privately scared of a new threat to their health will take actions. And so if you look at the Imperial College paper, they will say, assuming no spontaneous changes in individual behavior, which is just an incredible baseline to make, to say, well, there's going to be no change. And indeed, in the chat earlier, I think someone said, you know, the assumption is that no lockdown means do nothing. And that's just a really crazy assumption because people are faced by a brand new risk. Of course, they're going to do things. What we would call behavioral models tend to have plateaus of infection, which are well below the classic ones. Getting much closer to which my area as an empirical person using data is they're what we would call under-identified. The same model can give you enormously different predictions. And there was a really good illustration of that, which many people here will know. Swedish researchers who were critical of the official approach used in Sweden took the Imperial College type of modeling in mid-April, and they forecast that by mid-May, just 4 weeks later, there'd be 80,000 deaths, when actually it was about 3,500. Now, obviously 3,500 is a lot. It's very sad that there were so many, but the model was out by a factor of 20 over just 4 to 5 weeks. In the New Zealand case, some of you may be aware of Ian Harrison of tail risk. He used exactly the same simulation model as the Otago researchers, but he set tracing and isolation success at 50%. They set it at 0. This is the model which was widely used in March to say thousands and thousands or tens of thousands of deaths. Once he did that, the deaths fall by 96%. So these models are incredibly sensitive to changes in the assumptions. And so, as I said here, the answers tend to follow the assumptions in these models. That's not what I do. I tend to use, well, I always use, I never do mathematical modeling, actual empirical data. I rely on the deaths data. I'll admit straight off, the deaths data are not perfect. There's lots of variation across time and space in these, but they are far better than the data on cases because the data on cases reflects testing efforts. And so the first thing we can do is we can use, and I'll come back to this, and so we don't know what infections looked like because we didn't have any systematic population-based testing going on, serological surveys and so forth. So the distribution of the orange bars, we actually don't know that. But we do know reasonably well the distribution of the grey bars. And in New Zealand, we had press release at 1 o'clock every time to announce the sad reality of someone dying from COVID or with COVID. So we also have the cumulative distribution, this solid line up here. One thing to note, exactly because the infection fatality rate is so low, that the deaths on this axis are multiplied by 100. Otherwise, everything would be right along the base here because you wouldn't actually see them on the same scale, right? So this is simply a conceptual picture. Now, what we can do is, once we know the distribution of deaths, which we know much better than the unknown distribution of infections, there's a typical time of between 23 to 28 days from infection to death, so we can backdate the movement of infections. And when we do this for New Zealand, the lockdown came 10 days after the likely peak in the new infections. Of course, this is estimated statistically, so there's a little bit of uncertainty about that. The uncertainty is really small because this cumulative distribution function here fits extremely well. We can explain 99.75% of the variation from these functional forms. So that doesn't really change that at all. I've shown a logistic. We could use a Gomperitz, which is not symmetric like a logistic. It still doesn't change the conclusion. The New Zealand lockdown was not early. It was actually after the peak in infections has likely already been. And so in that sense, it was largely superfluous. Hamburg in Germany showed the same thing. Here's another way of looking at it. This is from the Oxford Blatnick School of Government. This is the stringency index, which takes into account, many of you will have worked with these, restrictions, school closing, mobility restrictions, border controls, and so forth. And what I'm doing to control this, and I'll just move in case it's blocking it, I'll zoom off. We've got rich countries who have no land borders, who are the right counterfactual for us. And so this is New Zealand, Australia, Iceland, Japan, and Taiwan. And this is looking at from mid-January until early April. And contrary to the go hard, go early, which is repeated ad nauseum, it simply isn't true. And so New Zealand, by and large, was lagging behind most of these countries. We're here, for example, in late February. Every other country in this group had much stronger restrictions than New Zealand did, until lo and behold, sometime on 23rd of March, there's this huge jump. And indeed, as many people know, we jumped to more restrictive than Italy, Spain, France, and countries who by that stage had thousands of deaths. Okay, and so hard but not early is the bottom line from that evidence there. And this matters. And so one thing to focus on here, we've kind of at the moment, there's been this sort of cult of personality and cult of policymakers. So you get articles, not just in New Zealand, saying, oh, it's because the policymaker was a female rather than a male that we've got variation in deaths, or it's because Orange Man is bad, we've got variation in deaths. And I'm certainly not supporting Trump. The reality is that much of the variation in death rates between countries are outside of the immediate control of policymakers. And so large countries have done worse. More densely populated countries and more urban populated countries have done worse. Countries with more immigrants have done worse, which matters perhaps for compliance of tracing if they're illegal, and certainly matters for the diaspora. Countries with more hospital beds have done better. Countries with more elderly have done worse. And the really big one, which matters for New Zealand, is it really helps to not have a land border, because then the only place you need to control entry is through airports and ports, but not across land borders. And so just these factors here, none of which policymakers can change in the short run, account for 2/3 of the variation in death rates between countries. Okay, policy accounts for a maximum of 5% of the cross-country variation, and it only matters if the policy restrictions came before the peak of new infections, right? And so half of the OECD countries, which includes New Zealand, put their most stringent policies in place after the peak in new infections, and almost all of that policy stringency is wasted. It's not reducing deaths at all, but it is doing considerable damage to all of the other health conditions and to the economy and so forth. Okay, so let me just, something's popped up on stream here. I'll get rid of that. Let me just go to one more of the same. What happened? Here we go. So we can use these relationships and we can do a couple of things. And so the first thing to note is it's much more important to go early than to go hard. And so going hard just does huge damage, and it doesn't seem to reduce death tolls at all if one goes hard too late. We can then also use, rather than using mathematical simulations, we can use the actual pattern of deaths across countries, and these are deaths up until October 8, and so it's very up-to-date death tolls here, to say, well, what would have been the deaths in New Zealand if we had had less restrictive policies? And since it's been the kicking boy for journalists who have been anti-lockdown, who have been pro-lockdown, I should say, then let's say, what if we had set policy stringency at the mean level for Sweden? Well, we would predict that New Zealand would have 330 more COVID-19 deaths than we actually had. Now, that might sound a lot or a little. I'll give you a metric for thinking about that later on, okay? And the other thing to note here too, because economists love worrying about endogeneity, so these policies were not randomly assigned. Those of you who haven't seen it, there's a very nice paper, again, it's a published paper, not a working paper, in Proceedings of the National Economy of Sciences by Sabatu et al. And what they show is that within a 2-week period in late March, pretty much all of the OECD, with a couple of notable exceptions, Sweden included, adopted homogeneous responses for very heterogeneous settings. So the countries were heterogeneous in terms of their preparedness, in terms of how many cases they already had, in terms of hospital beds, in terms of whether it was winter or summer, in terms of whether they had a densely populated population using public transport, or they were like New Zealand, and yet they used almost exactly the same set of policies, and it's as if they were either panicked or they simply copied from what others are doing because they were scared of being bullied for being the outlier, and the way that Sweden's been treated. People can understand why policymakers might have basically, this is the herd mentality here, which was adopting exactly the same response rather than a fit for purpose response for a particular country, right? So let me I'll do 2 more slides and then I'll just take a little bit of a break because I was advised to not do it all in one block. So lockdowns are typically superfluous because they come too late, but even if they come at the more appropriate time, they're largely ineffective. And why are they ineffective? Well, because the private response to risk and the response to less stringent public interventions like social distancing recommendations accounts for almost all of the decline in mobility, and therefore to the decline in spread of the virus and to deaths. And so Austin Goolsbee, who was President Obama's chairman of the Council of Economic Advisors, so he's certainly no right-winger, has a paper which shows that in the US, consumer mobility, measured by foot traffic and measured by Google and others, fell by 60%. 9/10 of that, so 90% of that 60% fall, was due to private responses, and only 1/10 of it was due to people responding to state and local government restrictions. Raj Chetty finds the same thing. Ideally, if we could do an experiment, we wouldn't necessarily do a cross-country experiment because there are still too many differences between Sweden and New Zealand or between other countries. And there are still differences between countries in reporting of COVID deaths. Are they with COVID, by COVID, and so on and so forth. And COVID is a very, very highly clustered disease. And if we look at Italy, for example, in Lombardy, it was death rate of 1,500 per million. The rest of Italy, it was just 300 per million. China, between Wuhan and the rest of the province and the rest of China, big difference. The US, big differences. And we see this everywhere. So it's much better to look inside countries. And so the US provides a nice, what we would call experiment, not a true random experiment, but economists are quite good at analyzing almost random experiments. 6 states in the US did not have a lockdown at all. And so the Dakotas, Nebraska, Iowa, Kentucky, Oklahoma, I think it is here. And then 3 states, Wyoming, Utah, and Texas, had county level decisions. And so Texas, a majority of counties had social distance, had lockdown, but some had social distancing. In Utah, it was the other way around. The variation is driven by political factors. And so the states without lockdowns all had Republican governors, and it's a state level responsibility, not a presidential responsibility. Turns out that lockdowns are very politically popular. So you're much more likely to have a lockdown if there's an election coming in November 2020, and in the US, only a rotating group of states have elections, so they don't all have their elections every year or every 2 years. And so there's only 11 states with elections coming up in November. And partisanship at the county level, the switch from Democrats to Republicans between 2012 to 2016. All of those predict the probability of whether or not a county has a lockdown. As best I know, the virus doesn't care about politics. And so these factors here should only affect deaths through affecting the probability of lockdown, not through some other mechanism. And that's what economists basically look for when we look for quasi experiments. So if the lockdown was as effective as pro-lockdown people suggest, and New Zealand's Prime Minister, of course, a very prominent one of those, we would expect that these counties here, which had social distancing but not lockdown, would have an explosion in coronavirus and an explosion in COVID-19 deaths. This is the pattern. Here's the 0 bar. The grays are the 95% confidence interval. This runs for 2 months, and there is simply no evidence at all of any difference in death rates between the counties which had lockdown and those that didn't. This allows time for them to evolve. We allow for endogenous policy. We allow for spillovers. And the key thing, which is a point I've made in a few places, is all of this evidence was publicly available to people in Treasury or MB or elsewhere to be using to supplement or replace the SimCity mathematical modeling, which has been so influential in New Zealand. And it's remarkable to me, as someone who teaches bright students to go off and do applied econometrics and go to the public sector, that I can find no evidence that any of this kind of evidence or the cross-country evidence was being used to actually look at empirical data rather than SimCity projections. So is it a good place to have a pause, and then I'll show you what some of these things mean for life expectancy in New Zealand, or should I just charge on?
John, I think carry on. We're getting a few questions through, but I've got questions, but I suspect you're probably going to answer them in the next section. Yeah, okay. So let me, might be worth jumping on. Yeah, okay, someone said charge on.
Okay, perfect. Okay, so we've got this huge focus on direct effects, you know, a focus where every individual death has the Director General of Health and a cabinet minister or a prime minister and so forth. And many people have noted, well, there's all sorts of indirect effects, and people have talked about some of these as, you know, deaths of despair, of unemployment, suicide, reduced immunization, delayed cancer diagnoses, and so forth. There actually was an analysis by SAGE in the UK, which showed that many of these pathways were amounting almost to as many deaths as directly came from COVID. The problem with this is it becomes a little bit like the whack-a-mole game, I should say, rather than goal, where each one you say, okay, well, here's one pathway. Someone said, oh, well, actually, we didn't have as many road deaths because everyone was locked down, so no one was driving around. My approach is much broader than that. Many of these indirect effects will flow through lower income, because the sad reality is that poorer people and poorer societies have lower life expectancy. So I'm going to show you a macro level. I'm not going to look at any individual particular pathway. And the key motivating thing, and Viscusi is basically the patron saint of risk analysis in economics and public health, is if we misperceive risk, and that gets at the idea as to whether or not the IFR is 0.2%, or if it's 1% or 3.5%. And if we have a media focuses so much on one risk, we'll excessively invest in reducing certain risks. And so we pay more than we should for health gains that are less than we could achieve. And this is going to be very much the case here, right? And so what I'm going to do is I'm going to say, well, what if we had these more relaxed settings, which the actual cross-country pattern of deaths, allowing for differences between countries and allowing for policy, would lead one to predict that New Zealand would have had 330 more COVID deaths if policy had been set at the Swedish level, not 80,000, not 8,000, not even 1,000, but 330. So that's going to be the direct effect. And then I'm going to look at the indirect effect, which will flow through lower income, right? And so basically, this is from the New Zealand life tables, and this is for males. And so, as has been noted, and Simon noted it earlier, some deaths which would have occurred will occur somewhat earlier, but it's very, very age specific. Note that this is not 1918. If you read Jeffrey Rice's book on Black November, the median age of death in the 1918 pandemic in New Zealand was between age 30 and 34. So the shifting in deaths is actually by a very small amount. I couldn't find individual level data for deaths in New Zealand. The Herald had an article back in April or May, which gave descriptions of each of the COVID victims in New Zealand, but made it broadly, you know, they were kind of about age 70 to 75 and so forth. So they didn't make it specific. Australia has actually quite good data on that, and it would be reasonable to assume the age pattern in New Zealand would be the same as in Australia. So in Australia, just over a third of COVID deaths have been amongst people aged greater than 90. 42% were aged between 80 and 89, 17% were 70 to 79, and only 7% were 69 or younger. And this is how Australia classifies COVID death. And so I think it's a reasonable approach. So 330 deaths, it sounds a lot. There's going to be a lot of 1 p.m. media conferences for Ashley Bloomfield and the Prime Minister to do if it was going to be one for everyone. What does that mean in terms of life expectancy? And I focus on life expectancy because I think a lot of people have an intuitive understanding of life expectancy, and also because life expectancy is going to enable me to do a health with health comparison rather than a health with money comparison. And there are some people who just seem very opposed to health versus money comparisons. So 330 more COVID deaths in New Zealand with this age pattern would reduce life expectancy at birth averaged across the whole of New Zealand population by 26 days. Okay, so by less than 1 month. So now what am I going to compare that with? Well, I'm going to compare that with the indirect effect, which comes from the fact that both over time, so this is New Zealand's real GDP per capita, here's the global financial crisis here, this is New Zealand's life expectancy, this is average between males and females, and so over the last 3 decades, life expectancy in New Zealand has gone up by 6 years, up into the low 80s here, okay? They both trend upwards, they are not in lockstep, and I'll explain why that may not be the case in a moment, but we'll be able to rely on the fact that they do indeed move together very closely, and they also move together very closely across countries. And so this is Chad down here, all the way up through rich countries here. This is from 2017. So basically what lockdown entails, or what a huge economic shock entails, is retreating along this income curve, retreating along here, which is potentially going to reduce life expectancy. And by how much? Well, we refer to what we call the income elasticity of life expectancy. And just in case people say, oh, this is just some neoliberal right-wing economist plot, I can find articles in the Lancet which have calculated the income elasticity of life expectancy. And so public health people use this as well. It turns out that New Zealand manages historically to get pretty good bang for its buck in that we're more efficient at converting rising incomes into higher life expectancies than are either the US or the UK. So in New Zealand, for every 10% rise in real income, life expectancy goes up by 1.7%, but conversely, if it falls, it's going to go down by 1.7%. For the US, it's 1.2, and for the UK, it's 1.2 for a 10%, for the UK, 1.5. And we also explain more of life expectancy in New Zealand by income. So 96% of the variation in life expectancy in New Zealand is explained by income in the long run. Now, lots of variables go up without being related. And so many years ago, in fact, a Nobel Prize winner who passed away, who used to visit New Zealand a lot, Sir Clive Granger, came up with this concept of cointegration, which says that 2 variables are moving together in the long run over time. And indeed, it's this case that for New Zealand, income and life expectancy, income, in this case, real GDP per capita, are co-integrated. So it's not necessarily the case that a 1-year fall in income is going to cause a 1-year fall in life expectancy right there. But over the long run, those things matter, because over the long run, it's the difference between being a very rich country with high life expectancy and being a lower middle income country, as New Zealand is slipping down the OECD ranks, with rather lower life expectancy and unable to afford various treatments. So What does the economic shock look like for New Zealand? So this is from the Treasury forecasts, and this is from the pre-FU just last month versus the half-year economic forecast in December. And so over the next decade, then the net present value of the GDP forecast for New Zealand now, compared with what was forecast pre-COVID, is 7% lower. So that's the long run effect, okay? And what that 7% lower means is that with an income elasticity of 0.17, then this is implying that life expectancy will be 1.2% lower than it otherwise would have been. And that's equivalent to 1 year of life expectancies that's lost, given our average life expectancy. So this is more than 12 times larger than the direct effect, even if we had had relaxed policies like Sweden, where we would have had 330 more COVID-19 deaths than we actually had. What we don't see, what doesn't get the 1 p.m. media conferences, what doesn't get the kind of ghoulish attention from journalists and politicians is going to be far, far larger than what we do see. And to me, as an economist, that's really wasteful and really actually very tragic. And so let me conclude. New Zealand wasn't early. The peak in new infections is likely to have occurred before the lockdown. Timing matters, and so it's much better to be early or to go early than to go hard. It's not true that we went early and hard. We went hard, but we went hard at a rather late place. Even if we had had timely policy settings, it wouldn't have led to a huge difference in the number of COVID-19 deaths, because far more important things which policymakers can't change in the short run matter. And so in terms of life expectancy at birth, we're trading off indirect effects, which are going to flow through unemployment. They're going to flow through lower incomes, and so expensive drugs aren't going to be able to be funded. They're going to flow through lack of immunizations, and all sorts of other things are likely to be 12 times higher in the New Zealand case than the direct effects there. And we also had throughout the lockdowns in New Zealand evidence from overseas that actually lockdowns are not really effective at all. And so I'm sorry, I probably went well over the 10 minutes which I had promised to take, and I'll stop the sharing of the slides so I can see people.